Perfect. Hi, everyone. Thank you all for being here, and thank you for granting me the privilege to talk to you about a case that I have. So my name is Michelle Sanchir. I am a medical student at Texas A&M College of Medicine, and I'm presenting a case of CMV pneumonitis in an immunocompromised patient receiving high-dose steroids. So cytomegalovirus is a double-stranded DNA virus, human herpes virus 5. It has fairly high seroprevalence in the community. Over half of individuals may have this virus as a latent form, but this seroprevalence significantly increases with age. So over 90% of individuals above the age of 80 will have this virus as the latent form. In immunocompetent individuals, infection is most typically asymptomatic, but if there is symptoms, it's very benign, very mild kind of mononucleosis type symptoms, fever, malaise, arthralgias. But in immunosuppression, the infection can be pretty significantly severe, and it can cause systemic manifestations such as CMV retinitis, colitis, and pneumonitis. And so our patient is an 86-year-old male. He has a history of giant cell arteritis and treated on 60 milligrams of prednisone daily. And he's been on this prednisone for about a month and a half prior to his presentation. He also has a history of lung adenocarcinoma, status post radiation therapy, and this was done in 2020. He also has a history of a cerebellar stroke in 2019 with residual balance and gait abnormalities. He also has a 42-pack-year smoking history with COPD and coronary artery disease with stent placement in 2019. He presented to us with a 3 to 4 day history of dyspnea on exertion, dry cough, malaise, as well as low-grade fevers with Tmax of 99. He was actually residing in an assisted living facility prior to this. And so at that facility, before presenting to our ED, he obtained a chest x-ray, and that showed bilateral infiltrates. And so at the facility, they started him on levofloxacin. However, his condition worsened despite treatment, and so that's why he's presented to us. And he, in the ED, he was found to be hypoxic at 86 to 88% saturation on room air. So we started him on 2 liters nasal cannula, got a CT chest, which shows here patchy bilateral infiltrates concerning for multifocal multilobar pneumonia. And so we started him on vancomycin and cefepime, and we were concerned about a possible stroke etiology as well. So we obtained an MRI of the head, which showed multiple punctate infarcts in the cerebellar, posterior parietal, occipital lobes. However, workup for a stroke etiology, including echocardiogram, MRA, was negative, non-diagnostic. We also obtained a swallow study, a fluoroscopy, to show if there's any signs of aspiration pneumonia, and that was negative for any aspiration. And of course, we did workup to cover our bases in terms of a source for community-acquired pneumonia, such as blood cultures. We tested for urine and the urine strep and Legionella antigen. We also tested for HSV, TB, mycoplasma pneumonia from bronchoscopy. And we also assessed for possible autoimmune vasculitis by assessing a full rheumatology panel. And this was done in progression because his clinical condition continued to worsen despite being on antibiotics. So our working diagnoses throughout this period of time included community-acquired pneumonia, aspiration pneumonia, radiation-induced lung fibrosis, and vasculitis. And so it wasn't until hospital day 7 that he underwent bronchoscopy with BAL. And the serum, the CMV PCR from the bronchoscopy came back positive with over 9,000 copies. And so that's when he was initiated on IV ganciclovir, and we sent the blood serum PCR for analysis to confirm viremia. And that came back a few days later with confirmation of viremia with over 200 copies in the blood. So our final diagnosis was CMV pneumonitis. Throughout his hospital course, he had increasing oxygen needs. So he required high flow nasal cannula, 50 liters per minute, scheduled nebulizers. He transitioned between high flow and nasal cannula, but did not tolerate being weaned off of the nasal cannula. We treated him with many broad-spectrum antibiotics, at first with vancomycin and cefepime, but cefepime was transitioned to ceftriaxone given concerns for neurotoxicity with cefepime. He also received a few doses of tazobactam piperacillin, but finally, when he was diagnosed with a CMV pneumonitis, that was when he was transitioned to IV ganciclovir for 1 week and then transitioned to PO valganciclovir with the goal of therapy for at least 2 weeks. And he continued to be on steroids throughout his entire hospital course for treatment of giant cell arteritis, as well as concern for lung fibrosis and vasculitis. His disposition showed resolution of viremia with weekly PCR checks, but however, he experienced hypoxemic respiratory failure, continued to clinically worsen, and he experienced encephalopathy, generalized weakness, and the decision was made to transition him to hospice after 4 weeks of inpatient treatment. So upon a review of the literature, CMV is widely noted to be prevalent in cases of significant immunosuppression. So some cases, common cases that come to mind include stem cell transplantation, organ transplantation, and these patients are often monitored. Their CMV status is often monitored prior to receiving transplantation, as well as the status of their donor. And certain patients who receive steroids in addition to organ transplantation are at increased risk. There have been several studies that have noted that patients receiving steroids after transplantation are at increased risk of CMV pneumonitis, and in general, most of these patients will receive prophylaxis with ganciclovir or valganciclovir. There has also been a documented case in which a 55-year-old male, previously healthy, who came in with COVID pneumonia, was found to have CMV pneumonitis after being on a course of steroids, and his clinical condition failed to improve. So he was also treated with 2 weeks of ganciclovir and discharged home. He improved and was discharged home with a steroid taper. And so this largely points to the suggestion that testing for CMV and atypical pathogens should be performed in any patient presenting with significant immunosuppression, including patients who have been on high-dose steroids for at least 2 weeks. And so if they are presenting with a history of immunosuppression and pneumonitis, then testing should be administered early in the hospital course as to improve mortality. Diagnostics for CMV, there is not a lot of, there is some conversation about this, in which the gold standard is through biopsy, histopathology, demonstrating the inclusion bodies, as well as immunohistochemical staining. However, in certain cases in which biopsy is not achievable, especially for pneumonitis, bronchoalveolar lavage with PCR, as well as blood PCR may be diagnostic, in which treatment is initiated and recommended. And certain literature has demonstrated that there is not a standardized cutoff for either the blood PCR or the tissue PCR, but certain studies have demonstrated that a cutoff of 10,000 copies for tissue PCR, if a patient is above that and does not show any signs of viremia, they still warrant treatment. However, if they are below 10,000 copies and demonstrate some level of viremia, then they would still warrant systemic treatment with ganciclovir or valganciclovir. In terms of the viral load for the blood, it has been documented that 500 might be an appropriate cutoff, but especially for our case, in which we had around 200 of a viral load in the blood, it is not necessarily a true cutoff for recognizing and testing and treating CMV viremia in a patient with a history of immunosuppression. So at this point, these are my references, and I will conclude my presentation and accept any questions that the audience may have.
It's a wonderful presentation. Thank you so much. I think you kind of touched on this in terms of your patient, but we did have a question, and if there's some generalities or if you'd like to kind of expand, what does follow-up care after CMV colitis look like?
So for CMV pneumonitis,
The question in the chat says CMV colitis. So that,
Oh, yeah, my presentation is about CMV pneumonitis for the patient, but I anticipate that the follow-up might be similar, particularly for patients with pneumonitis. This tends to be very fatal if left untreated, or not recognized and diagnosed early on in the course. So I anticipate if a patient presents with CMV pneumonitis and they are treated appropriately, for a duration of at least 2 weeks on ganciclovir or valganciclovir, anticipate if they continue to be in an immunosuppressed state, then it is recommended to monitor the levels of the virus in the blood by PCR. How frequently this may be, I think, depends on the degree of immunosuppression, but especially if they are showing signs of any kind of disease progression, then more aggressive intervention may be appropriate.